This meeting is now being recorded.
Hello, my name is Dr. Kathy Chow-Flinch, and I would like to share with you today the results of my doctoral capstone work entitled Implementation of a Nutritional Algorithm to Enhance the Pressure Ulcer Prevention Program, a Quality Improvement Project. Pressure ulcer prevention has been around for a long time, and in 2008, the Centers for Medicare and Medicaid Services, which is known now as CMS, implemented very strong regulatory changes which impacted many things related to hospital-acquired pressure ulcers. What it implemented was CMS would begin denying reimbursement payments. It would impact pay-for-performance and value-based purchasing, certainly impacted patients' pain and suffering, and hospitals that have magnet status would be negatively impacted by hospital-acquired pressure ulcers. The problem statement for this project is that there is a lack of nutritional support for structured pressure ulcer prevention program. The organization is at risk without intervention for patient outcomes, financial risk, and increase in the hospital-acquired pressure ulcer rates. To give you a little background, Carilion Medical Center, which is located in Southwest Virginia, is a 700-bed, level 1 trauma and academic center. In 2008, when CMS made all the multiple changes related to regulatory compliance, pressure ulcer became a priority at Carilion Medical Center. We implemented such things as specialty surfaces and mattresses, pressure ulcer prevention rounding, incontinence management, repositioning devices, and our hospital-acquired pressure ulcer rates became below the national benchmark, and they currently reside below the national benchmark. We implemented many best nursing practices, but the one thing that we significantly lacked in was adequate nutritional support as part of the prevention model. The purpose of this capstone project was to determine if wound champion frontline nurses' knowledge about effects of malnutrition related to skin integrity, wound healing, and pressure ulcer prevention improved following an educational program. The other piece of this was to implement a nutritional algorithm. What you can see before you is actually the nutritional algorithm which we developed and integrated into our electronic medical record. This algorithm was developed after doing an extensive literature review to see what was out there from a best practice perspective. What we found was at St. Vincent Medical Center, they had a model very similar to this. And as you go through the algorithm, you can look at this patient from admission all the way through to discharge. And it is based on the Braden score. And if the Braden score is low enough, then nutritional supplements are added into this patient's diet. And I'm glad to share this with whoever would like to have a copy. The project question for this study was, is there a difference in levels of knowledge among nurses about nutrition and pressure ulcer prevention before and after an educational intervention? When I was considering what theoretical framework to utilize, Donabedian's framework came to mind. His health services research was phenomenal based on 3 very simple steps, and that was structure, process, and outcome. I added issue here because I felt like it was important to identify what the issues were early on. So as you look at this algorithm or you look at this framework, you can see that we had identified a gap in the current program, which was a lack of nutritional intervention. With the structure, we implemented the algorithm and integrated it into our electronic medical record. and develop the nursing education component that would be shared both with the wound care champions and with all of nursing. The process was to really measure the nursing knowledge on malnutrition and have the wound champions complete the questionnaire, provide education, and then retest the group at 9 days after the education was completed to measure success. The overall outcome is nursing knowledge did improve, the nutritional algorithm was implemented, and further plans were developed for implementation into community hospitals. When completing the LIT review, I focused on 4 areas that really helped to solidify what I was focusing on for the project. And these references are available if you would like to have them. One was to determine a correlation between early identification of risk factors and development of HAPUs. The second, need for structure process for assessment. The third, implementation of evidence-based initiatives consistently improved over a pressure ulcer program. Many studies also demonstrated that if an additional of oral nutritional supplements were added to patient stay, that there was a decrease in the opportunity to develop pressure ulcers. The methodology used for this project was a quantitative pre-test, post-test comparison using a questionnaire. And we would be measuring nursing knowledge about nutrition and pressure ulcer prevention and explore the effectiveness of an educational intervention. The project design was the questionnaire, the pre-test and post-test. Then the educational component, which was the nutritional algorithm, the nutrition and pressure ulcer prevention, utilized a convenient sample, and the sample was the frontline nurses of the wound champions. And these wound champions are considered to be the experts on wound care at the unit level. There were several considerations from an ethical perspective that I needed to consider. One, needed to obtain approval from the Institutional Review Board, or the IRB, from both Carilion Clinic and American Sentinel University. There were several potential risks that I identified early on. Because I am a senior director at this organization, I wanted to make sure that participants felt comfortable with participating in the study. So that was a risk that I identified early on. Nurses with any direct or indirect reporting structure to me were intentionally excluded from the study. It was important for participants to not feel coerced or manipulated during the project study. Informed consent was explained, and a hard copy was provided to participants to read completely and then sign the consent. Once informed consent was completed, the participants was given a copy of the signed consent. The participants were then given a pre-assigned unique identifier, which the participant would use for both the pre-test and the post-test for identification. Also, they were asked to provide this number on both the pre- and the post-questionnaire. This was to ensure confidentiality, and the participant would remain anonymous. Participants were also informed that they could change their minds at any time and decline to participate during the project. The data has been secured in my office under lock and key and will remain there for the next 5 years. The methodology used for this quantitative study was a descriptive and statistics, a paired t-test, ANOVA, a Tukey's test, and a Pearson's correlation, and utilized the SPSS software. The project variables were, the dependent variable was the nursing knowledge, and the independent variable was the oral nutritional supplements and the algorithm education. The instrument that we utilized was the questionnaire, which was developed by me. In looking for a questionnaire, I was unable to find one that would suit the purpose of the study. So in looking to see what I could do, I decided to develop this questionnaire, and it would be based on all of the literature review that I did during this process. Developed 20 evidence-based questions using a 5-point Likert scale, measured nutrition and pressure ulcers prevention knowledge. In order to validate the validity of this questionnaire, I utilized 3 experts, which reviewed and approved for content and structure. And also, this, as I said, this information came straight from the literature. Reliability was also a factor that needed to be considered. And so the internal consistency via Cronbach's alpha analysis was completed, and the post-test was 0.56992, which was moderate internal consistency. The key focus areas for the questionnaire included signs of symptoms of malnutrition and the impact to patients, the Braden score and the significance of the Braden score, the nutritional algorithm, and the overall assessment. Oral nutritional supplements, and then to educate, encourage, and assist the patient. Looking at the data collection, management, and analysis plans, as I stated, we utilized a unique identifier that was provided to each participant to ensure confidentiality. The pretest was administered to 22 participants. Education was provided to participants after that, and that was a didactic approach. Then the post-test was completed 9 days after the education. There was an 86% return rate of completion, or a total of 19 participants. In looking at the analysis, I looked at demographic analysis, which included the descriptive statistics, age, entry-level degree, highest level degree, and years of experience. The analysis showed a significant correlation between the age and highest degree earned, which was a Pearson's correlation coefficient, which was at -0.524, and a p-value which was equal to 0.021. As age increased, the highest degree earned decreased. Completed the paired t-test and had 2 questions that were significant. Questions 8 and questions 11 demonstrated statistically significant findings. And question 8 looked at the overall importance of the ONS and would that decrease the risk of pressure ulcer development. The paired t-test was a negative 0.68 and the p-value was equal to 0.000. More nurses strongly agreed with this true statement on the post-test. And on question 11, the oral nutritional supplements can decrease the risk of infections in patients at risk for malnutrition. The paired t-test was a -0.47, and the p-value was equal to 0.001. Again, nurses more strongly agreed with this true statement from a post-test perspective. During the results of the ANOVA, there were several questions that, during the pre-test findings, that demonstrated significance. The questions are here for you to read. What I'm going to do is to share with you what the actual results were. In question 1, discussing the Braden scores, the entry-level bachelor nurses disagreed strongly, whereas the diploma nurses strongly agreed with this statement. And the Tukeys was 0.25. In question 2, this was related to malnutrition would be easily treated, and this was a false statement. The 4 to 6 years of experienced nurses disagreed more strongly with this false statement, whereas the 7 to 9 years of experienced nurses agreed. The Tukey's P was equal to 0.33. In question 4, which was a false statement, it stated that it was unusual for patients to be admitted with undiagnosed nutritional issues. The P value was 0.02. Unable to perform a Tukey's test here because one of the participants did have a master's degree. On question 7, the older nurses more strongly agreed with the statement that stated changes in ADLS such as loss of mobility and changes in body functions are symptoms of malnutrition, and the Tukey's was 0.032. And in question 17, which was related to discharge planning and stated that it was not important to patients who were being educated on the oral nutritional supplements. This was statistically significant difference. The Tukey's was P of equal 0.29. For the post-test findings, on questions 9, the older group more strongly disagreed with this false statement, and the Tukey's P was 0.036 between the age groups of 32 to 39 and greater than 40-year-old nurses. In question 10, there were several findings. The question was, nutritional needs are only the responsibility of nutritional services. These findings included 3 different answers. The Tukey's P equals 0.042 between the age groups of 18 to 24 and 32 to 39-year-old nurses. The younger group more strongly disagreed with this false statement. The second response, the Tukey's, was 0.045 between the age groups of 25 to 31 and 32 to 39-year-old nurses. Again, the younger nurses more strongly disagreed with the false statement. The last result was a Tukey's of 0.021 between the age groups of 32 to 39 and greater than 40-year-old nurses, and the older group more strongly disagreed with the false statement. In question 12, this was a false question related to nutritional needs of not being any significance to pressure ulcers, and the Tukey's was 0.037, and the associate degree nurses more strongly disagreed than the bachelor nurses. And in question 15, which was a true statement related to the nutritional support is very critical for treatment and prevention of pressure ulcers, the Tukey's P was 0.024, and the associate degree nurses strongly agreed than the bachelor degree nurses with the right answer to the question. So what does all this mean from an interpretation of the results? It was very clear to me that this quality improvement project did determine that the nursing knowledge gaps based on education levels, years of overall experience, and age were significant. Further identified further education needs on pressure ulcer prevention, nutrition, and overall patient education. And the disappointing thing was that our frontline RN participants, who were the wound champions and the frontline experts at the unit level, were unable to provide the correct responses. So in looking at the questionnaire, determined that we really needed to consider rephrasing and rewording questions on 9 and 10. Needed further clarity. Also, there needed to be additional education related to signs and symptoms of malnutrition. That clearly was a deficit that was determined from this study. And to implement strategies that would improve and impact sustainability, maintain our current NDNQI level, which is below the benchmark results, and continue to educate the frontline wound champion and the nursing unit. This project did demonstrate the need for heightened awareness of nutritional needs. It also strengthened our overall pressure ulcer prevention program because we did implement the algorithm and we did implement all of the other things that have been mentioned. Also, we identified that with the need to improve overall patient outcomes would be impacted by expanding nursing knowledge. This study does have the potential to impact pressure ulcer prevention both nationally and internationally. There is the potential to improve patient outcomes based on expanding nursing knowledge about nutritional support, and also will potentially improve hospital finances related to overall length of stay changes, decreasing CMS reduction of payment related to pressure ulcers. When I went back to review how Donabedian's framework was utilized in this project, I identified 5 questions that really answered the pressure ulcer prevention challenges that we were looking for, and there really was no significant difference identified from a pre-test to post-test. The invaluable information provided from the questionnaire responses included identifying that we definitely needed further education. Outcomes identified was that there was a knowledge gap in pressure ulcer prevention, malnutrition, and overall patient education needs. There were several things identified in this project as being limitations. The sample size was one of those limitations. When I completed a power analysis, the minimum sample for a one-tail hypothesis was 102 participants, and the minimum sample for a two-tail hypothesis was 128. So this project was not statistically significant, but it is clinically significant. The convenience sample may not have been the right sample to utilize, so that could be seen as a limitation. The reliability and the validity of the questionnaire, the Cronbach alpha test was less than 0.70. The post-test was a 0.56,992, which is a moderate internal consistency, but to have a strong, reliable, and with validity, you really need to have a Cronbach alpha of greater than 0.70. The time frame between the education and the post-test could be viewed as a limitation, and the potential for bias due to me working at the facility could also be viewed as a limitation. There are several recommendations for nursing leaders that I feel like are important. One is to really look at your current pressure ulcer prevention program and evaluate your current needs, including completing a gap analysis. The one thing that I did back in 2008 was to hire a clinical nurse specialist. That was the pivotal point of us turning our program around. Consider utilizing the skills of a CNS. Invest in that education of the frontline staff early on, which would include skin integrity and pressure ulcer prevention, nutrition, and just getting back to basics. With all of our technology and things that we have going on from a nursing perspective today, sometimes we just need to get back to basics. Also consider early implementation of nutritional interventions. That is so very important. Recommendations for future research. I hope that this study will be replicated by expanding the sample size. Consider additional practice settings such as home health, physician offices, community settings. Consider evaluation of nursing knowledge needs in a variety of practice environments, and develop an online educational tool with focus on pressure ulcer prevention and nutritional needs and potential interventions. And we did implement that process into our electronic knowledge base, and it has been very instrumental in helping to educate people. Examine pressure ulcer learning opportunities for physicians, nurse practitioners, physician assistants. CMS expects our providers to be able to manage the pressure ulcers and overall prevention programs, but unfortunately that is an area that needs so much attention. And it's a good thing that we can partner with our providers these days to really try to get the best care for our patients. So in summary, this quality improvement project did answer the project question, is there a difference in levels of knowledge among nurses about nutrition and pressure ulcer prevention before and after an educational intervention? Donabedian's health model provided the framework for the QI project using the triad approach of structure, process, and outcome. I would like to thank my capstone committee for the many, many hours that they spent providing me guidance and counsel. Dr. Helen Heitzel, who was my chair, who was phenomenal in just helping me get through the process, Dr. Michael Landry, and Dr. Kimberly Hall. I cannot begin to thank you enough for your support during this whole process. I have provided my email contact. If you have any questions or would like to talk further about this project, please feel free to reach out to me. I would love to be able to help you and answer any questions that you may have. Thank you for viewing my presentation.